So 3, 2, 1. You can start the session, sir. Over to you.
Well, good evening, everybody. Today I'm going to talk to you about a drug named Ticagrelor. All of you have heard about this drug. It's one of the very important and potent antiplatelet agent, which cardiologists are very familiar with. But it's also important for physicians to know about it because many patients, after their angioplasty or after percutaneous intervention, or even after medical treatment of ACS or post myocardial infarction, they come for follow-up with the physicians and they should know what this drug is all about. So in initial slides, I'll be talking about certain pharmacological aspects of the drug, followed by certain important clinical trials. And at the end, we'll talk about some special niches or some caveats about this drug. So in the past, all of you were very much aware and familiar with clopidogrel. Now, clopidogrel was the drug which was very often used along with aspirin in patients with acute as well as chronic coronary artery disease. Now, it remained the gold standard along with aspirin for several years. And it remained as a sheet anchor of dual antiplatelet therapy after percutaneous intervention. So what was the need for the new drug like Ticagrelor? So there are some important issues that stent thrombosis continued to occur, in spite of dual antiplatelet therapy with clopidogrel and aspirin. And investigators suspected clopidogrel resistance as one of the important mechanisms for this failure of DAPT following stenting. Now, studies showed that clopidogrel is a pro-drug, means it's not the active form of drug. When whatever you take by mouth is a pro-drug, which is ultimately later converted into the body or in liver into the active metabolite. It has got the active metabolite is a very short-lived agent. It is mildly potent and it has got slow onset of action. And there is a large inter-individual variability between individuals for the same dose of clopidogrel. So these limitations were associated with adverse ischemic events, including stent thrombosis. So now we have new potent antiplatelet agents, which are called P2Y12 receptor antagonists. And these are prasugrel, ticagrelor, and cangrelor. Now, today we are mainly going to focus our discussion on ticagrelor. Cangrelor is one drug which is used intravenously, and it's not available in India, and it's rarely used even in Western countries in certain situations. Prasugrel and ticagrelor belong to the same kind of group of drugs, and we'll talk about the differences between the two subsequently. Now, for the sake of ease and convenience, I'm going to address ticagrelor as Tica and prasugrel as Prasu, so it becomes easier to pronounce. Now, this is the molecular structure of Tica, which is it's chemically called as cyclopentyl triazolopyrimidine. Now, this is an important slide where you can see here clopidogrel is this blue thing is a prodrug. So it is whatever you eat, it's a prodrug which is converted into liver by oxidation into an active metabolite. So this red circle is an active metabolite which acts on platelets. Now what happens with prasugrel? It is also a prodrug, but it is hydrolyzed by esterases in the intestine, and it is converted into active metabolite. So nothing happens in liver. While clopidogrel, oxidation, CYP-dependent oxidation occurs in liver. So this is with prasugrel and clopidogrel. What about TICA? TICA itself is an active drug. So it just see, it's right from the beginning, you eat it as an active drug and it directly acts on platelets as an active drug. So common sense tells you that when you have an active drug like this, which you eat by mouth, the onset of action is going to be quick, isn't it? Because unlike clopidogrel and prasugrel, it is not going to be converted into, from prodrug to active metabolite and then acting on platelets. It's directly absorbed and it acts on platelets. So that's important. So it does not require metabolic activation. It has got a rapid onset of action. So if you take loading dose of that is 180 milligrams of TICA, it has got, its peak action comes in about an hour or two. It has got greater inhibition of platelets than clopidogrel. So if you study the platelet activity in the laboratory, it's 90% effective. TICA is 90% effective, but clopi is only 60. Now, the degree of inhibition of platelets reflects plasma concentration. It has got quicker onset of action, and that is why the functional recovery of the circulating platelets is quick. Now, Ticagrelor, all of you must be knowing that it produces a symptom of breathlessness. Now, many times it creates confusion. It's not exactly breathlessness. What it is patients feel like taking a deep breath. Now, this side effect is because of increased levels of adenosine in the blood. So TICA produces increased levels of adenosine in blood, and adenosine is a very good molecule for the vasculature. Now, because of increased levels of adenosine, it causes anti-inflammatory action. It has got cardioprotective action, cerebroprotective action, and so on. So that is important. Now, this table tells you the comparison between clopi, prasu, and TICA. Now, I'm not going into each and every detail of the table, but it's simple to see here that these are metabolically inactive molecules which are converted into drug later, while TICA is an active compound itself. Main loading dose, TICA is 2 tablets of 90 milligrams stat followed by one tablet twice a day, while prasu, you have to take 6 tablets stat and 1 tablet a day. Now, in terms of its inhibition of platelets, clopidogrel and prasugrel cause irreversible inhibition of platelets, while TICA produces reversible inhibition of platelets. So this is important to know, because when you stop the medicine, the offset of action is quick with ticagrelor. So you have done his angiography, patient is on TICA, the patient has 3 vessel disease or left main and he has to go for surgery. Now, if the patient is on TICA, you just stop TICA and the action will be gone within a couple of days, maybe 3 days, 2 to 3 days. While with clopidogrel and prasu, it takes almost 5 days to a week. And the clinical trials have shown that if the patient is on prasugrel, the incidence of profuse bleeding following bypass surgery is very, very high. Now, in terms of efficacy, TICA and prasu both are more potent than clopidogrel. Bleeding risk, of course, the more potent the drug, the more is the bleeding. So bleeding is higher with prasu and TICA, and we'll talk about it in detail subsequently. Now, what are the issues with these drugs? In clopi, you get rash, which is seen as a side effect, while prasugrel is contraindicated in patients who are more than 75 years age, less than 60 kgs, and who have got prior TIA or stroke. While there is no such contraindication for TICA. The only side effect which I mentioned about to you was dyspnea, which was seen in about 15%. But sometimes it is so irritating that patients end up stopping or requesting the doctor to stop TICA. So many times, if you can just reassure the patient that this is not serious, this is a result of some metabolites, some good metabolites like adenosine in the body, patients usually understand it, and many times, they subsequently settle down. Now, this is an important clinical trial which is called TICO Trial, which was a comparison of TICA versus clopi in patients with acute coronary syndromes. This is a very important and seminal trial, and where patients with ACS were included. All patients received aspirin. Patients who received thrombolytic therapy were excluded, and patients were either randomized to TICA followed by loading followed by maintenance, or clopi loading followed by maintenance. Total 18,000 patients from 43 countries were recruited. What were the endpoints? The primary endpoint was a combined endpoint of cardiovascular death, MI, and stroke. Well, primary safety endpoint was total major bleeding. And what did the scientists see? It was clearly seen that the primary endpoint of death, MI, and stroke was reduced significantly with ticagrelor than clopidogrel. Now, this percentage drop is almost by 2 points, 2.2 percentage point reduction in the absolute risk of developing death, MI, or stroke. So this is very, very significant. And the number needed to treat was 53. So if you give this drug to 53 patients, you will save death, MI, or stroke in one patient. Now, what about the bradycardia? Some patients with TICA, it was thought that they developed bradycardia, but you can see that there was no difference in the incidence of pauses or bradycardia between clopidogrel and ticagrelor. The incidence was same. So it's not, the risk is not increased. But you can see that incidence of dyspnea was significantly more in patients with ticagrelor. Of course, as I told you, this dyspnea is not something which you need to worry about, but at the same time, some patients request the cardiologist to stop their medicine because of this irritating symptom. Now, what this benefit, at what cost did it come? Did it cause more bleeding? Well, thankfully, the answer is no. Both ticagrelor and clopidogrel, with both, the incidence of major bleeding using any criteria, it may be Plato criteria, TIMI criteria, any fatal bleeding, there was no difference in bleeding between clopi and ticagrelor. So the conclusion is it gives you benefit in terms of reducing the risk of death, MI, and stroke, but does not increase the risk of major bleeding. Okay. So these were the conclusions. Now, this is another important trial, which is called Pegasus TIMI trial. Now here, TICA was used not in acute situation, but it was used in patients with chronic coronary artery disease well after prior myocardial infarction. So who were the patients? These were the stable patients with history of MI 1 to 3 years prior, and addition of one risk factor like age more than 65, diabetes, second MI, multivessel disease, etc., and renal dysfunction. And these patients were randomized into 3 groups. One was high dose TICA, low dose TICA, and placebo. And then they were followed up. And it was very interesting to see that the main endpoint, the endpoint was, as I mentioned, did I mention it here? The endpoint in this clinical trial was same, the death, MI, and stroke. And you can see death, MI, or stroke incidence was significantly reduced in patients who received both doses of TICA, low dose as well as the high dose, as compared to placebo. And there was no difference between low dose TICA and high dose TICA, although the incidence of bleeding was little more in patients with high dose TICA. Now, it's not only important to note this, but it is also important to see that the duration of benefit was continuous for almost 3 years after the onset of clinical trial. So the effect of these drugs is very, very persistent, long-standing, and patients continue to benefit from this drug when they are given the medicine post myocardial infarction. Now, here is the bleeding issue. It is very clear that when it is compared with placebo, the incidence of bleeding with ticagrelor goes up. So it's very clear. But as against the previous trial where it was compared with clopidogrel, there was no difference because clopidogrel is also an also an antiplatelet agent. But here it's placebo. You can see that the incidence of major bleeding as well as the minor bleeding was higher in patients who received ticagrelor, and the incidence of bleeding was lower as compared in low dose as compared to high dose when you compare these two groups. So the conclusion was addition of TICA at a dose of 90 milligrams twice a day or 60 milligrams twice a day to low dose aspirin reduced the risk of cardiovascular death, MI, and stroke, and increased the risk of TB major bleeding among patients who had MI 1 to 3 years earlier. And I would like to add that this benefit was sustained over 3 years following the initiation of the drug. Now, I would like to switch now to another very important trial, which is a Twilight trial. There are two trials, Twilight and TICO, and we'll be talking about both these trials back to back. Now, let's talk about Twilight trial first. Now, all of you know that you must have seen so many patients following angioplasty in your clinical practice. Almost all the patients are receiving dual antiplatelet therapy. Now, it has almost become a norm that patients would remain on dual antiplatelet therapy after stenting. Now, people started asking questions that now we have better antiplatelet drugs like TICA. Can we not switch to single antiplatelet agent after stenting? Because the risk of bleeding following dual antiplatelet therapy is substantial. So this particular trial and TICO trial were conducted. Now almost 7,000 patients were randomized at 187 sites across 11 countries in the world. Now, what was the protocol? For first 3 months, all the patients received TICA and aspirin. Now, after 3 months, one group was randomized to TICA plus aspirin, that is dual antiplatelet, and the second group was randomized to TICA and placebo. So aspirin was not given. Only TICA monotherapy was continued in these patients. And rest of the treatment was according to the standard of care. And patients were followed for 15 months. And what did they see? That this is the incidence of bleeding, bar 2, 3, or 5 grade. You can see that the first important thing to note was when you give as TICA monotherapy, the incidence of bleeding goes down substantially, almost reduction by 50%, 7.6 to 3.6. It's very, very important. Bleeding risk goes down very substantially. What about its efficacy, like death, MI, stroke? No difference. So it's a very, very important clinical trial which tells you that after 3 months, a patient who has got an angioplasty can be on aspirin, TICA monotherapy. Now it's important to remember that this is for a routine patient, but there are certain subgroup or subtypes of patients in whom you would not like to switch to monotherapy, like patients with left main angioplasty, patients with more than 3 or 4 stents, patients who have got a high risk of stent thrombosis. Here you might want to be a little more careful, but in a run-of-the-mill common case after angioplasty, this can certainly be practiced. Now, this is another trial which is called TICO trial. It's exactly similar trial. 3 months of DAPT followed by single TICA based monotherapy. And the only difference was this was a stent was used in this trial. It was an ultra thin bioabsorbable polymer sirolimus eluting stent, or SIRO. So this was a stent trial as well as a DAPT versus mono antiplatelet therapy trial. It was similar, 3 months DAPT followed by monotherapy. And what did they see? This was a net adverse clinical event. So they combined, what were the net events? So monotherapy, the net adverse events were substantially lower, and which was seen, at the 12 months as well as 3 months analysis in terms of major bleeding as well as the net adverse cardiac events. So this is very, very important. So again, what are the key learning points? TICA monotherapy after 3 months of DAPT showed a significantly lower risk of net adverse clinical events than currently recommended TICA-based 12-month dual antiplatelet therapy. This indicates that TICA monotherapy could be an optimal strategy, balancing both ischemic and bleeding risks for patients with ACS treated by this particular stent. Now, this is for TICO, but for Twilight, which we saw before TICO, that had nothing to do with a particular type of stent. It can be done with any type of stent which is used. So what are the highlights of Ticagrelor? This is my last slide, but I'm going to dwell on this slide for some time. First of all, the highlight is it's a more potent agent than clopidogrel, but it is as safe as clopidogrel. So the bleeding risk is similar, but the ischemia risk is reduced very, very significantly as compared to clopi. It has got very quick onset of action. So this is important when you take the patient to the cath lab. Patient comes to the casualty with ACS, and you want to take him to the cath lab. Now, if you give this patient ticagrelor on table, the chances that you will have some kind of antiplatelet action soon after the procedure or during the procedure are higher as compared to clopidogrel. It is reversible. It is reversible quickly, simply because, as I told you, it has got it doesn't bind to platelets irreversibly. There are no contraindications. As I mentioned, that if you are using prasu, then you cannot use that drug in patients who are more than 75 years, less than 60 kgs, and who have got history of TI or stroke in the past. There is no such contraindication for TICA. There is no resistance like clopidogrel. At least it's not been reported yet. So when you give TICA, the cardiologist or physician, they don't have to keep worrying about resistance and stent thrombosis because of it. It is effective in ACS regardless of how you manage the patient, by angioplasty, stenting, or by medical management or whatever. Another important thing is TICA can be chewed. For rapid onset of action, you can ask the patient to chew it, or you can crush it with a crusher and then ask the patient to take it. It doesn't reduce its activity and efficacy, but the absorption becomes faster. It can be given as a single agent 3 months after PCI, as it was seen in Twilight and TICO trial. So I would stop here. I have discussed most of the important things about TICA, and I can take questions if there are any.
Hello.
Yeah, can I stop sharing my screen?
Yes, sir. I will stop from here, sir. Okay, sir.
Okay.
So there are a few questions from attendee side. So I have just put in a Zoom chat box. You can see it, sir. Can you see it? Otherwise, I can read for you, sir.
Yeah, because I'm not able to see it anywhere.
In chat box.
In chat, yeah. There is a question here. As per your statement that patients discontinue TICA due to price issue, nowadays generic brand, I never said they discontinue because of price issue. I did not say that. I said they discontinue it because of dyspnea, a symptom of breathlessness, which is actually not breathlessness, which is a sensation of, compulsory deep inspiration. It's like, because like adenosine effect. As far as price is concerned, you're right. I mean, price is not a big issue now, because now there are so many companies making this drug, and the price has come down substantially. So that's not an issue anymore. Then the other question is, which antiplatelet is more prone to cause stent thrombosis, either prasugrel or TICA in your clinical practice? Well, actually, prasu and TICA, in terms of efficacy, in terms of inhibiting platelets, they are similar. And moreover, prasu binds to platelets irreversibly. So, in terms of stent thrombosis in clinical practice, I don't think there is any difference between prasu and TICA. There certainly would be an important difference between clopi and prasu, or clopi and TICA. There will be a difference, because clopidogrel is a weaker antiplatelet. But in terms of efficacy, prasu and TICA would be same. But it's important to remember that incidence of bleeding after prasugrel is much higher and much more serious than TICA, because of its irreversible binding to platelets. That's important to remember. Then last question is, how long should we continue TICA 90? And if 1 year, then can we use TICA 60? Yes, absolutely. The Pegasus trial has shown that in terms of efficacy, TICA 90 and TICA 60 after myocardial infarction is similar. Both are equally efficacious in terms of reducing death, MI, and stroke. And the effect is persistent for at least 3 years after initiation of treatment. But as far as treatment of post angioplasty patient is concerned, if you want to treat the patients on dual antiplatelet, we don't have any data about 60 in a big trial. So whatever duration you use it for the potency of the drug. You use it in 90 post PCI. And as I told you, that both in Twilight and TICO, dual antiplatelet with TICA aspirin can be used for 3 months, followed by TICA monotherapy, 90. Another question, any difference between the low-cost brands and Brilinta? I mean, now this is something which is very, very difficult to answer, because in terms of, unless you conduct a trial, you will never know. But, from whatever little experience we have of using both these, it's very difficult. There is nothing grossly apparent. And if you really extrapolate your experience of just these low-cost brands versus the regular brands in other areas, like, for example, anti-failure drugs, or ACE inhibitors or ARBs, there is not a huge difference in their efficacy. But as the time passes, we will know whether there is a real difference between the two. Are there any other questions? Can you hear me? Are we on, or?
Hello.
Yes.
Sir, right now there are no more questions in the chat box. So should we conclude or wait for the more questions?
I can wait. If you want me to wait, I can wait. No problem.
Okay, sir, no problem. We can wait for more question.
Yeah.
Hello.
Yes.
Sir, so I think there are no more queries or confusion from attendees side. So
Okay.
can I conclude the session with your permission?
Yeah, sure.
Okay, sir. So I would like to thank you on behalf of the organizer for your insightful and educative talk. Thank you, sir. And thank you to all dear delegates and doctor for attending today's session. So I am ending this